Green. All right, fun. We're going to talk about GYN ultrasound. All excitement of ovaries. So I think probably the most important thing that especially residents I don't think quite grasp is the relationship of the bladder to the uterus and then how it changes. A lot of times during fast exams, I will get videos of just the uterus and not a bladder. And so I don't think people realize the kind of how the uterus can actually sit on top of the bladder, especially if the bladder is pretty empty. Um, and then understanding the location of the ovaries in relationship to the uterus, and then especially the iliac vessels. So here's a typical transverse view, right? So you got your bladder on the top, here's your uterus on the bottom, and then this actually has some beautiful ovaries. This is stolen from Yale. So you got right ovary, left ovary and right ovary over here. And then up here, you can actually see the iliac vessels kind of coming through. So again, bladder, ovaries. You guys cannot see my mouse. It's not helpful. There you go. So bladder, uterus, ovaries. And then you can see iliac vessels coming along here and here. And then the ovary kind of running between the iliac vessels and the uterus. Some more examples of just ovaries. This one is probably a little polycystic because there's quite a bit of follicles in there. And you can see that there's a little bit of fluid around the ovary as well. So if this patient came in complaining of sudden onset pelvic pain, especially in the setting of intercourse, this would be very suggestive of a potential ruptured cyst, especially with that little surrounding free fluid. And then once you go to the short axis, right, you just rotate probe marker up towards the head. And then we want to look in long axis. I think the important thing to realize, and I'm not very good at ever finding the cervix. And so what I typically do is I use the point of the bladder to kind of aim to where the cervix would be, which is right about here. And so here's your vaginal stripe coming up. Right here is your endometrial stripe. You can see there's a little bit of free fluid. This is an anteverted uterus, so it's pointed anterior. And then cervix lives here. So that's important when you're trying to figure out placenta, previa, and things like that, knowing where the cervix sits. Again, you got cervix right at that point, the fundus, right, the fluid in the cul-de-sac, and then there's your vaginal stripe. So here's another example. And then this is a nice bonus because you can actually see ovary as well. And then ovaries have that very typical chocolate chip cookie looking appearance too, where you can see some follicles. And we'll talk about the difference between a follicle and a cyst. It's just a size difference. The other important thing, again, also when it comes to looking at pregnancy ultrasounds, is identifying where your endometrial stripe is and making sure you're looking there for your IUP, because an IUP anywhere outside of that stripe is an ectopic. So it could be a corneal ectopic, an interstitial ectopic, a cervical ectopic, but not a pregnancy that should continue, or at least needs radiology confirmation. And then again, here's bladder. So here you can see that anteverted uterus. So you can understand now when students and beginner learners are scanning and they might see this rounded structure, right, with a little hypoechoic something in the center and think that's bladder because they don't understand that the uterus sits on top of the bladder most of the time. And then as the bladder grows, it'll push that uterus that's on top of it kind of back. All right. So it's important to understand the difference between transabdominal and transvaginal ultrasound. The big thing is going to be your bladder. So transvaginal is going to be an empty bladder. Super uncomfortable to have a transvaginal ultrasound with a full bladder. Plus, it also distorts your image because it pushes the uterus away from your probe. And transvaginal probes are essentially a high frequency probe. It's the equivalent of a linear probe, just sort of curved. So you get this eagle eye view, but very shallow. So you get 5 centimeters or so. So a large bladder is going to push that out of your way. So it definitely needs to be empty. Again, high resolution, you're not going to get a lot of depth. Primarily, this is going to be for POCUS use, is going to be fetal dating and IUP confirmation, usually before in the 6 to 8 week or before 6 to 8 weeks. And then the typical teaching is always transabdominal first. see what you can find transabdominally before you jump over to transvaginal. There's tons of stories of women coming in with pelvic pain. They went to do a transvaginal first and they see like a baby's head. And they're like, what is going on, right? So always transabdominal first. And then generally you can see, depending on body habitus, about 6 to 8 weeks, you can start to see IUP transabdominally. Again, this will get you more depth, less dilution. But the most important part is that your bladder has to be full, because now you're using your bladder as your window to look through your uterus. Cool. So that's your typical transabdominal one. We're all kind of comfortable with that one. Transvaginal, again, you can tell because you get this curved probe, again, matches the curvature of here. And then this is a long axis view. They're getting them, they're rotating a little bit. So this is kind of what you're going to see. So in long axis, you're going to get the fundus, and then you're going to see the endometrial stripe up here. And then depending on where you're aiming, right? So usually what you would do is you would rock up on the probe, so it's going to look down, and you're going to kind of sit it right in this posterior fornix area so that you're kind of right up against the cervix, and then you can visualize the uterus. And so this is what it looks like up juxtaposed to an actual view. So again, the cervix is going to be right next to you, and then you're going to get the endometrial stripe right here, and you can see again the cul-de-sac fluid. Then you would rotate your probe into a short axis, and then now you're visualizing the uterus in cross section. So again, here's cross section. You can tell it's transvaginal because of the footprint up here. Here you can see uterus, and then you can actually see both ovaries right next to it. You can see there's a little bit of free fluid in there. And then again, long axis. This is what an IUD looks like. On ultrasound, it's actually a little bit hard to tell IUD versus like endometrial stripe on transabdominal, but it's usually just this hyperechoic structure with some shadowing, and it should lay right in the endometrial stripe for a properly placed IUD. All right, so how do you find ovaries? So there's two ways you can do it. So the first one is you can start in long axis and then sweep over to find the iliac vessels, and then start to slowly sweep medial. And the ovary should live somewhere between the uterus and your iliac vessel. So that's kind of like a nice way to try to find it in long axis. The other way you can do it is in short axis. And basically you're going to scan through and you're going to find the corneal region of the uterus. And that's basically where the uterus is its widest. And then you're just going to kind of scan over, and you're going to follow that wide part out. I personally prefer the long axis view because I find it's easier to find iliacs and then sweep to uterus. But whichever way works, just know the ovaries are pretty mobile and they should be able to move and slide. So that's one of the tests that you want to do, is actually a sliding test. You put a little bit of pressure and you should see the ovary kind of wiggle or move. If it doesn't, that's going to suggest things like PID and some adhesions. I think those were the big things. Yes. Okay, so we're gonna go through pathology. All right, so the first one is ovarian cysts. So just like renal cysts and liver cysts, right? Anechoic, thin-walled, unilocular, posterior acoustic enhancement. There you go, posterior acoustic enhancement. So it's considered a physiological cyst if it gets greater than 2.5 centimeters. So if you have a follicle, essentially those are normal. Under 2.5 centimeters, that's a follicle. Over 2.5 centimeters, then that's considered a cyst. And then they can range anywhere from like 2.5 to 15 centimeters. Again, the larger the cyst, the higher the risk of torsion as well. So here's another example. Again, there's your ovarian cyst. We're in short axis. You've got uterus hanging out over here, and then thin-walled, unilocular, right, posterior acoustic enhancement. Again, same thing, suggestive if there's some surrounding free fluid, suggestive of potentially ruptured cyst. So physiologic, less than 2.5 centimeters, follicular, more than 2.5 centimeters. So that's like that weird differentiation. Sometimes you can have complex cysts, Okay, so again, we're in long axis. There's uterus. We're sweeping over. You can see this is ovary here. And you can see that there's some internal echoes and septations in here. So here's another one. Again, within the matrix of the ovary, you can see right here, multiple internal echoes. So if you see this, this can be suggestive of a hemorrhagic cyst. So again, we're short axis. You can see uterus and cross section with that endometrial stripe. Cool. Any questions on that one? Kind of straight. All right. The next one's pretty cool. We did get a lecture on this one, which is ovarian hyperstimulation syndrome. Not very common, but you'll see this in fertility treatments. So especially women on Clomid, where they're trying to induce a lot of egg production. And sometimes their ovaries go a little bit too crazy and start to like stimulate, and they get like just crazy cysts. A lot of them rupture. They get like this crazy free fluid. This is your spaceship sign from all this free fluid. This patient specifically was actually hypotensive because of all of her ruptured cysts and was like a peritoneal belly. She was actually quite sick. Very sweet woman, but very sick. So again, you can see all these crazy cysts. Her ovaries are ginormous. And then you can see the free fluid around them all. So this is a nice example of ovarian hyperstimulation syndrome. Okay. So the most important one, I think a lot of people want to know about, is torsion. And so the big thing is understanding that torsion is more a clinical diagnosis and not really a radiographic diagnosis. And I'm going to explain why. But basically on ultrasound, a couple of things you're going to look for. So one, the ovary should be enlarged, right? Because what happens with torsion is the ovary starts to get vascularly congested. And so that congestion starts to make the ovary swell. As the ovary starts to swell, this isn't really a great example of it, but the follicles start to get what you say peripheralized. So you start to see this like spoke wheel appearance where the follicles start to go on the periphery of the ovary. So you have an enlarged ovary with follicles on the outside, and then you get a little bit of fluid tracking around the ovary as well. All right. So in summary, an enlarged ovary, the peripheralized follicles, the heterogeneous stroma, right? So the texture, echo texture of the ovary starts to look bright, dark, light, white kind of to it. You're going to see some surrounding free fluid. The other big thing is you're going to have decreased venous return. The reason we don't use arterial flow is because the ovary actually has two arterial supplies. And so it gets one off the uterine ligament and it gets one off the ovarian artery. Uterine artery and the ovarian artery. So if this side torses, but this side still stays open, you're going to have arterial flow to the ovary. So arterial flow does not rule out torsion because of this dual blood supply, because women are inherently more complex than men. So it's really important to understand that part. So this one is actual torsion, and you can see that there is still flow in this ovary, even though it's torsed. So again, you'll see radiology, they'll put it on like their caveat when they do their like transvaginal ultrasound reads that torsion is a clinical diagnosis and cannot be ruled out with ultrasound. So again, super important to understand. Here, enlarged ovary, right? Heterogeneous echo texture, peripheralized follicles, and then some free fluid around here. And then the adage, right, is normal sized ovaries don't torse. So if the ovary is a normal size, it's probably not torse, which is a nice way to kind of do a little check back. So this one versus this one, right? You can tell which one is torus and which one's normal. You can see a little bit of variation in the vascular flow, but there's still some flow, but it's definitely not nearly as impressive as the normal ovary. So again, same thing. So normal flow, this is color power Doppler. Do you know what color power Doppler is?
Not quite PTI one, I think.
So this one just tells me flow, but not direction. Whereas regular color Doppler, yes, exactly. Yep. So this one is just telling me if flow is in or out, but I don't know if it's coming or going. I just know it's there. exactly. All right. Some ovarian masses, a little less exciting, but things you can look at is if it's benign, it's going to be more like the unilocular. If it has some solid component to it, it's going to be small. There's going to be some acoustic shadowing. It's just going to tell you it's fluid filled. It'll have smooth walls and then typically no vascularity to it. Whereas if it's malignant, it's going to be solid. It'll be irregular shaped. Whoa, that was weird. Irregular shaped. They'll have ascites with it. That's going to be a really big clue. So if you see ascites with some sort of ovarian enlargement, be concerned. Irregular walls, enlarged, and then there's going to be vascular flow to it. So this one, I don't know what's going on with my computer, is a cystadenoma. So these are actually pretty benign masses. Sorry, I don't know why this isn't a thing. So these are pretty benign masses, but they are the largest of the ovarian neoplasms. They're capable of growing to occupy actually the entire abdominal cavity. So these can get super huge. They're multiloculated cystic masses. They have fewer internal or no internal echoes. Septations are usually there. And if you actually do a little bit of pressure, the septations will wiggle a little bit. So some gentle transducer palpation will make these septations kind of wiggle jiggle. In the benign form, there's usually no solid component to it. But if you see any solid component to it, now you're thinking about a cystadenocarcinoma, which is going to be cancerous. Again, these are going to be more mixed cystic and solid lesions, heterogeneous. They're going to have some solid component to it here, and then they're going to have vascularity to it. You can also look for ascites. If you see ascites, that's usually linked with peritoneal metastatic spread. And then this is a dermoid or a teratoma. These are the second most common ovarian masses. And then solid teratomas often contain fatty tissue that can be echogenic on ultrasound. Cystic, which is like this one, can be mostly fluid, so cystic, or complex, which is both solid and cystic components, and malignant transformation can occur. So these actually do require follow-up. PID. So there's 4 ultrasound markers of PID, which I actually didn't realize before I wrote this lecture. So the first one is some fluid in the cul-de-sac, multicystic ovaries. If you see the fallopian tubes on ultrasound, that's really uncommon. And then obviously a adnexal mass or suggestive of a tubo-ovarian abscess. So one of the things you can look for is the ovaries themselves actually get hazy. So that you lose that distinct margin of the ovary and it kind of just blends in with its surrounding. Again, when you push down on top of the ovary, it doesn't move because of the adhesions, because it's tethered, because of the inflammation. Free fluid. A lot of ovarian cysts is also suggestive of PID. And then if you can see the fallopian tubes or you're an adnexal mass. So this is an example of a transvaginal ultrasound with PID. And so you can see that the margins are really like hazy and kind of indistinct. And then there's a little bit of dilation of the fallopian tube over here. This is another one, right? Lots of fluid in the posterior cul-de-sac. It makes me feel better when there's images like this in a textbook and you're like, wow, that's really overgained and that's pretty terrible. You're like, mine just can't be that bad. Again, here's multiple ovarian cysts. And then this is just a dilated fallopian tube filled with fluid. And then if you put color flow over these like weird things, right? If it's an ovarian cyst, it shouldn't really have flow to it. Whereas if it's a tubo-ovarian abscess, you're going to get this hyperemia or this ring of fire where you get this like increased vascularity around it. And again, here's another example. So you'll see this also with ectopics. You can get this ring of fire, and then the corpus luteal cysts also ring of fire. So you'll hear that those words again. So again, hyperemia. And you can see this is kind of purulent looking fluid filled. This is an adnexa, and this is a TOA. We're moving on. Fibroids, fun times. There's a couple different types. Intramural fibroids. are the ones that live inside the muscle. You have subserosal, which live kind of just right underneath the lining. You have pedunculated, submucosal, which are the ones that kind of project into the uterus. And then there's also fundal subserosal, which those are live on the top of the fundus. You can have pedunculated ones that live kind of outside of the uterus. So this is a pedunculated one. And so a lot of this kind of looks like masses to me and badness. So my general approach is if I see something like this, I just get an official ultrasound. I'm not going to be the comfortable calling this, which is solid looking tumory thing, right? Just a fibroid. So I'd let radiology make that call. This one is hard to see. And so the whole point is fibroids within the muscle belly actually create this linear, like striated shadowing appearance. And that's kind of common, actually. It has to do with the way they reflect the sound waves. There's usually significant shadowing distal to the fibroid, and it actually makes it really hard to see. And even with high frequency imaging, it makes it really hard to see. The other thing, fibroids, is that they can be isoechoic, hyperechoic, or hypoechoic. And they can also have calcifications within them. So they might have little bright stuff in there. And then they can also be associated with pregnancy. So this is a large fibroid associated with a pregnancy. Again, will make pregnancies a little more complicated. And then fibroids can degenerate, which are actually extraordinarily painful. And when you get cystic or fluid filled within these fibroids, it's usually suggestive of a degenerating fibroid or necrosis. Okay, almost done, actually. So retained products. So the big thing you're going to look for is, so obviously clinical, right? They're going to come in with vaginal bleeding, either post-delivery or an IND or some sort of abortive procedure. And you're going to have increased thickness of the endometrial stripe. Vascularity within there does help support the diagnosis, but you may not have any vascularity and it could still be retained products. So just because there's no vascular flow doesn't mean it rules out retained products that could still be there. So here's another example. Again, transvaginal, we're in the transverse view. This is the uterus. And here you can see just a very thickened endometrial stripe. So again, suggestive of retained products. So they say suspect it if the endometrial thickness is more than 10 millimeters. If it's less than 10 millimeters, it's a pretty high negative predictive value of about 60 to 80% for retained products. So less than 10 millimeters, unlikely retained products. More than 10 millimeter endometrial stripe, likely retained products. Bicornate uteruses, they're kind of fun if you find them. They come in different flavors. So the first one, this is probably the rarest, is the complete, where you actually have two completely separate uteri where they share one cervix. You can have a partial where there's like two smaller cavities, but above the cervix, they merge into one. And then you can have an arcuate, which just has like a little bump inward. So here's an example. This is a bicornate uterus that actually has an IUP in one of the uteri. And this can be associated with like increased risk of miscarriage, especially if they're complete. And then IUD we kind of touched on already. Again, on transabdominal ultrasound, these can be hard to see, but you're just seeing this like hyperreflective material. And again, it should be living within that endometrial stripe. Anywhere else, it's malpositioned. Nabalthian cysts, you'll see these pretty commonly. And so within the cervix, you just see a dilation with hypoechoic fluid-filled structure that are simple. It's from endocervical glands that get obstructed and dilated. Very benign, very common. Usually causes no symptoms and no pathologic significance. Hematocolpos, do you guys know what that is? So this is, yeah, what is it? I actually did a case presentation on this one at AIUM. It was a case report that someone presented. was like a young girl with lower abdominal pain.
Oh, yeah, it's, is it like I think it's been like prepubescent, like,
Not prepubescent, pubescent.
someone's
Yep.
got kind of first period.
Yeah, so what happens is yeah, so that the hymen is imperforate. Yep. Exactly. So this is all basically period blood within the vaginal canal. And because that hymen is complete, the blood can't get out. And so at some point, it's going to sort of bulge up in the hip, like mass capacity, and cause pain. A lot of times these patients will actually present with like urinary retention. So you have like little girl that like can't, not little girl, but like a teenager or early menarche that can't pee. And there's like tons of reports of like the nurses finding this because they go to straight cat them and they see this like giant purplish bulge in the vagina, like coming out the introitus. And they're like, doctor, you need to come here and look at this. This is really weird. But if you stick the probe on their belly, you will see this ginormous, like echogenic structure. So if you ever see something bizarro like this, just think, especially if they report either they don't get their period yet or they have just like scant spotting every month, it might be that they have the hematocolpos. And then I think the last thing is Bartholin abscess. So again, just like your typical abscess and just your linear probe, put it over the area of question. Oh, I don't know why this didn't look, sorry. And again, echogenic material, posterior acoustic enhancement. And then there should be a squish sign when you push down, put color flow on it, make sure that there's no internal vascularity. This was a cool case we actually saw. She was post C-section and came in with abdominal pain, and we just happened to be ultrasounding her. And if you know, so here's the uterus. You can see there's like her endometrial stripe, and there's this kind of weirdness over here. You can see it's kind of stretching out and coming over here, and there's some internal echoes. There was no internal vascularity to it, and this actually ended up being a uterine abscess of her C-section incision. So it was a interesting case, not on my differential of post C-section abdominal pain. Cool. That's all I got.